Good afternoon or good morning, depending on what time zone you're in today. This is Kathy Reynolds. I'm the Vice President for Health Integration and Wellness at the National Council for Community Behavioral Health, and I'm pleased to be with you today to provide a workshop and webinar on working through confidentiality issues as it relates to integrated healthcare. In the webinar today, we're going to review about 6 core concepts in confidentiality when doing what I call bi-directional integration. Bi-directional integration means that you're bringing primary care services into mental health or substance abuse sites, and or you're bringing mental health services into primary care sites. When you do that, there's a series of confidentiality rules and regulations that would cover the work that you're doing, beginning first with HIPAA, 42 CFR if you're doing substance abuse work, state confidentiality policies if you have contracts with the state to provide mental health or substance abuse services, and then elements that we use to address these federal and state rules and regulations such as privacy statements, consent forms, and business associates language. We'll review each of these items and talk about how it impacts on the work that you're doing in the integration of the services. This first chart is one that I put together for a chapter on confidentiality in a book called Raising the Bar. And it shows 4 levels of confidentiality. And often when we start talking about this, we start at level 4, assuming that we need to have a consent from every single individual that we are working with in order to release or share any kind of information. That is the most conservative approach. And when we're talking about substance abuse treatment, it is the approach that we have to take. But there are ways under 42 CFR and under HIPAA and under our confidentiality rules and regulations that we can share information about consumers to help them with their care. And that's what I want to talk about as we move forward here today. First, starting with HIPAA. Most folks generally think that HIPAA prevents us from sharing information in the healthcare world. In actuality, HIPAA creates more opportunity for us to be able to share information than we had before. The key element in HIPAA that allows us to do that is something called the Organized Healthcare Delivery System. And on the screen right now, you see the actual language from the HIPAA law that explains the Organized Healthcare Delivery System. It's for clinically integrated care settings where individuals receive health care from more than one healthcare provider. So what it is if you're working with another organization and you're both providing health care to the same individual, you can come together as an organized healthcare delivery system, and under HIPAA you will be able to share information. To be an organized healthcare delivery system, you and your partners need to hold yourselves out to the public as participating in this joint arrangement, and you have to do at least one of the following things that you see on the slides as partners. A utilization review activity, where you're looking at how consumers and folks that you serve, patients, are utilizing the health care that you're providing. Or a quality assessment and improvement activity, where you're participating together in providing care. Doing integration would meet either one of those items, but you need to decide which one you're going to do and then do it. That would allow you under HIPAA, now I need to be clear here, it's only under HIPAA, but it would allow you under HIPAA to share information related to those activities about the patients that you're working with. There are other elements that you can use that you might want to think through, such as payment activities, and then group health plans, which I don't believe would apply to those of you in the audience here today. But you can become an organized healthcare delivery system between you and your partners, and that will allow you to share information under the Health Information Portability and Privacy Act. We did this in the organization that I worked in Washtenaw County, Michigan, and we had an organized healthcare delivery system between our hospital, the University of Michigan, our community mental health center, a number of our mental health providers, and a number of our substance abuse providers were included in our organized healthcare delivery system. It was anyone in the continuum that we were working with where we needed to share information about consumers. After we became the organized healthcare delivery system, we did 2 additional things. As HIPAA requires us to have privacy statements, all of the organizations in this system, in their privacy statement, inserted a couple of paragraphs that were identical that said that we were participating in an organized healthcare delivery system, who was a part of it, and that by doing so their information would be shared across those partners. So we included it in our privacy statement, and if you went to anyone who was part of that system, the same privacy statement language was included in everyone's privacy statement. On the consent to treatment forms that we had to have for everyone who received treatment in our system, we had the same paragraphs indicating to them that by consenting to treatment, they were consenting to us to be part of this organized healthcare delivery system. And as part of that system, under HIPAA, we would be sharing information around their healthcare with each other. So we had, as you see here, to become an organized healthcare delivery system, the CEOs of the organization need to declare that they are creating such an organized healthcare delivery system in a letter to each other. That's all it takes. That's all the law requires, is a notification to the organizations from the CEOs that you're going to be participating in an organized healthcare system. In that letter, you identify what the QI, or utilization shared activity, is going to be, because you'll remember from our previous slide that to be in an organized healthcare delivery system, you have to hold yourself out as being such, and you have to have one QI, or utilization activity, that you're doing together. Once those letters are completed, you then include the nature of the organized healthcare delivery system in each organization's privacy statement. And again, I recommend that you sit down together with the folks that are participating in this organization and write this privacy statement language so that it's the same in everybody's privacy statement. And then the final piece is have it all reviewed by an attorney. Everybody has privacy officers, everybody has corporation counsels, and when you're dealing with privacy and confidentiality, you want to make sure that all of those individuals agree with what you're doing. So if you want to pursue this, if you have partners that you would like to create the organized healthcare delivery system, this webinar provides you with the language from HIPAA. You can get with your privacy officer. You can develop the concept with your partners, draft your letters, and draft your QI and utilization activity. And this will help you with your integration to be able to share information back and forth without creating HIPAA violations as it relates to the services that you're providing. And this has been a great way for folks to address these kinds of issues. And over the course of several years, we've even worked with states and the Office of Attorney General in states to have the organized healthcare delivery system accepted as a mode of addressing HIPAA privacy and confidentiality issues. So a solid and useful mechanism that you can use to feel comfortable sharing information under HIPAA as you move forward with your integration efforts. Now, in looking at the configuration of health centers, a number of you actually hold yourself out as providing substance abuse services or provide residential treatment. This would bring you under the auspices of 42 CFR Part 2, which is the federal rule and regulation that covers substance abuse confidentiality. This is the rule or regulation that is most often cited for why individuals or organizations that provide substance abuse treatment cannot share information. And what we're finding across the federal level, and I referenced some federal documents here that are available on our website for you to look at, is that 42 CFR protects treatment information. It was designed and covers organizations that hold themselves out as substance abuse treatment providers and are licensed to provide substance abuse treatment. Those are important and key elements that I just talked about, because what this means is that if you're in a primary care setting and your primary care setting is not a licensed substance abuse setting and you don't hold yourself out as providing substance abuse treatment, you can within your healthcare clinic share information around the substance use or abuse of those that you are treating. You can share screening information if you're using the Cage Aid or the Assist or the MAST or DAST, which are evidence-based screening tools. You can have your patients take the screening tool, and you can share those information and data that come from them across your providers in terms of understanding the level of use or abuse that's going on with that consumer. What's also fascinating is that primary care organizations, because they are not covered by 42 CFR, again, unless they hold themselves out as providing substance abuse treatment and are licensed, you may share this information with other organizations when you're making a referral. For example, say you've screened in primary care and you've found someone who has a major substance use or abuse problem, and you want to refer them to a substance abuse treatment organization. Your staff can call that organization, make that referral, and provide them the information on the screening tool that you have completed in primary care. You can provide them the score that they received on the tool that you've used, and you will not be in violation of 42 CFR. Now, if you've called a licensed substance abuse treatment agency, that agency that you've just provided that information to is going to be covered under 42 CFR and cannot release that information further. So again, one of the key elements here when you're talking about 42 CFR Part 2 and confidentiality is determining whether or not you hold yourself out as providing substance abuse treatment and or you have a license for the provision of substance abuse treatment, because 42 CFR applies to those organizations and ways of providing services. So if you're still concerned and interested and want more information on this, in June of 2004, SAMHSA actually did a great document that compares the HIPAA requirements for confidentiality and privacy with 42 CFR Part 2. There's a great document. It's on our website. When I say ours, I'm talking about the SAMHSA HRSA Center for Integrated Health Solutions. And we have that document on samhsa.integration.org. I'm sorry, it should be .gov. I'm sorry on that. That's an error on the slide. So it should be samhsa.integration.gov. So if you go to that website, you'll be able to find this wonderful document that takes the elements of HIPAA and compares them to Part 42 CFR Part 2 so that you can see if you're being covered in the work that you're doing. Also, with the work that's been going on with integration, Dr. Wesley Clark at CSAT has worked with his staff to issue 2 sets of what they call FAQs, or frequently asked questions, about 42 CFR. Again, great documents on our website at samhsa.integration.gov. And by going there and pulling those questions, you'll see the very things that I've just talked with you about. It'll talk about the fact that it covers treatment information. It'll have the discussion and help you sort out whether you're a covered entity and thus are covered by 42 CFR. It will also answer a number of other questions that you may have related to the provision of substance abuse services and sharing information. Another element of 42 CFR Part 2 that's important to the work that we're doing is that as a substance abuse treatment organization, you can complete what's called a qualified service agreement, which will allow you to engage in conversations in settings around your services. It will allow you to talk around in global elements around the consumers that you're serving. Again, if you're going to share substance abuse treatment information, you have to have a release of information from each individual consumer. So if you're going to talk specific consumers and specific substance abuse treatment, as a covered entity, you're going to need to have that release. But you can participate in meetings with groups across the country and talk about, in global ways, the types of consumers that you serve, the types of services that you have, and under a qualified service agreement, help with referrals and communication on that, again, as a covered entity. So in looking at the makeup of the folks who could be participating in this webinar today, those of you who are licensed substance abuse agencies, 42 CFR Part 2 is going to apply to you, and you're going to need to create not only qualified service agreement to share your substance abuse information, but I would also encourage you to do an organized healthcare service delivery to cover HIPAA. So, to address the federal rules and regulations, and the two that we're going to talk about, you need to do the organized healthcare service delivery element, which is the letter between the CEOs creating the delivery system. And then for your substance abuse providers who are participating in that organized healthcare delivery system, you're going to have to go a step farther and create a qualified service agreement, which will then allow you to exchange an additional level of information as it relates to substance use and abuse with your providers. I think the good news here is that often when we go to have conversations with organizations, folks say, well, HIPAA prevents me from talking with you, or 42 CFR prevents me from talking with you. Hopefully, as you listen to this webinar and as we have question and answers at the end, we'll be able to allay the fears that you have that these two federal rules and regulations actually protect rights, but they also do allow, under appropriate and legal circumstances, the exchange of information for care coordination and helping consumers and patients who need help get the help they need. Again, you have to have this discussion with your privacy officer and your corporation counsel. I was lucky. In the organization that I worked in, my corporation counsel said that he would rather defend me for having released information and saved someone's life than to defend me for having kept information confidential but having had a bad outcome for the client or the consumer. Again, that's an individual attorney's opinion, and you may have a more conservative corporation counsel who won't take that position, but at least from my organization, our corporation counsel tended to allow us to share more information to save lives rather than to stay with confidentiality and have bad outcomes for those that we serve. Another thing is, I think sometimes in the mental health and behavioral health field, which I've worked in for 30 years, we actually create more stigma by not sharing information and by not communicating information with health professionals than we do in terms of breaking stigma down. Because when we allege that our information is so confidential and that no one should see it, it implies that there's something wrong with that information or something wrong with that person. And so I actually think if we can move to a level of feeling more comfortable under the appropriate legal mechanisms that we're talking about in this webinar to share information, we'll see better outcomes for consumers and improved relationships among those that we serve. So I hope this is helpful to talk about these federal rules and regulations. The other reason that this is key is that working in the integration, as I have for the past 15 years, when I work with primary care settings, one of the things that they talk about when they try to work with mental health and substance abuse organizations, they say that we're like black holes. And what they mean by that is that if a primary care practitioner refers somebody to us in the mental health or substance abuse system, and they happen to call over that next day and ask if I showed up or you showed up for treatment, what do we say? Well, we say nothing. We say, well, we can't tell you that because of confidentiality. That makes them really upset with us. The norm in a primary care setting is that if a primary care physician refers somebody to specialty care, for example, if they refer someone to an endocrinologist to have their diabetes checked, the primary care provider will get a wonderful letter back from that consult saying that they saw the patient, what they thought about the situation, recommendations they have for care, and that is the norm in the primary care environment, as you all know. Well, we aren't used to doing that in mental health and substance abuse. If somebody gets referred to us, we grab them or not. They may not show up, but we don't do that follow-up. We don't secure that release if we feel we need one, but we don't send the information back to that primary care provider so that they know what's happening with their consumer. And we all know that these mental health and substance abuse issues that we're working with significantly impact recovery from primary care issues. So we have to figure out a way to comply with the law, but more importantly, to have our patients feel comfortable with the work that we're doing and having us share this information, because it's critical to their recovery. It's critical to their future life, and it's critical to their health care. So I want to move on now from the federal HIPAA rules and regulations and the 42 CFR Part 2 and talk about mental health and state substance abuse and substance use disorder policies. As tribes, this may not apply to you unless you are receiving funds from the state to provide mental health and substance abuse services for them. If you accept state funds, you may be required to follow the state rules and regulations as they apply to confidentiality for these issues. Absolutely, you have to follow HIPAA and 42 CFR. Whether or not you have to follow the state rules and regulations depend on the contracts and the situation in each state. If you do, you'll often find that these mental health and substance use policies are even more restrictive than HIPAA. So you need to double check and see if you have any contracts that bring you under these confidentiality policies for mental health and substance abuse in a state and review them carefully. I want to share with you an opportunity, though, that I really liked. It's probably the shortest piece of legislation that I have ever seen. And this was done in the state of Washington. Individuals were concerned that they wouldn't be able to share information, and so they went to their legislature and had this one paragraph law passed so that they could share information. And you can see here that it says treatment records of a person may be released without informed written consent in the following circumstances. Now, previously, as you know, the only time that we could release information was if someone was a danger to themselves or others, and then we could release that information to law enforcement agencies and the person who was at potential risk. What Washington did is they went a step further to help facilitate the integration of mental health, substance abuse, and primary care, and said that organizations could share when it was consistent with the requirements of HIPAA, which is the Organized Healthcare Delivery System, when we're providing services to a shared patient. It does, as HIPAA does, protects psychotherapy notes. So we can't share psychotherapy notes, but for care coordination, for referral, for coordination of care, they used some language that said, in accordance with HIPAA, we can. And as you see, you can share information back and forth across office staff to obtain medical records for licensed professionals. So really liked this law and wanted to share it with you because this was going on in the state of Washington, and people were saying, even with what I'd shared with you about HIPAA and 42 CFR, well, the state of Washington's rules and regulations were so much tighter, they needed legislative relief to be feeling comfortable to do their integrated health work. And this was what the state of Washington was able to do to help support their organizations in being effective in releasing information and sharing that. So we've talked about the federal rules and regulations. We've talked about exploring if you need to have any kinds of relief from state rules and regulations and or need to have them. Another way that you can create a way to share information across sites is through what we call business associates agreements. This, again, is a HIPAA rule and regulation, but it's a contractual agreement that we enter into with each other where we say that we're going to be business associates. And as business associates, we are going to share a variety of information. Most often, business associates agreements talk about sharing billing information and payment information, claims information. So having a business associates agreement would allow you to submit bills, pay bills, submit and talk about claims information, all of those sorts of things that would be covered under billing practices, but it doesn't have to be limited to billing practices. You can have a business associates agreement that would cover a variety of other elements that you might be sharing in that are not payment issues, particularly for organizations like yourself where you have funding from the Indian Health Service. Payment issues may not be a substantial issue for you. but you could, in addition to doing the organized healthcare delivery system and qualified service agreements, you could create business associates agreements that talk about a series of business agreements that you're going to have related to the services that you provide. And again, if you think back to that slide I showed at the beginning that shows the 4 levels, some organizations are very comfortable with qualified service agreements in the organized healthcare delivery system only. They stop at level 1 and 2 in terms of protecting information. Other organizations go all the way down to level 4. So it's, again, your approach to risk, how much risk you want to assume, how much risk your privacy officer is open to, and what your corporation counsel will say when and if they need to defend you in a case. But there are these 3 types of agreements that you can put together that show that you understand the rules and regulations of the law and have done everything you can to provide good service while ensuring privacy and confidentiality. So let's now go down to the 4th level of protection, if you will, in the privacy confidentiality area, and talk about release forms and consents to treatment. We talked a little bit about this when we were talking about HIPAA, in that almost all organizations have a patient or consumer sign a consent to treatment. This is an overarching statement where the individual agrees that they have come to us for care, that they want us to provide this care, and that they are consenting to providing care for us. You may remember that this is where I said if you're an organized healthcare delivery system, you'll want to have a paragraph in there that says you're an organized healthcare delivery system and these are your other partners. So by consenting to treatment with you, they're consenting to your sharing this information in an appropriate way with your partners. I've also worked with some folks in the state of Missouri to put together a community release form. They weren't comfortable with the privacy statement information and the consent to treatment. Although they did that, they wanted a specific release form. So what they did is they put together a standard release form that was used by all of the agencies that were part of the organized healthcare delivery system. And when someone came in, it was very much like a traditional release form, although instead of being from one agency to another, it listed all of the agencies that would have access or that you might be able to share the information with, so that it was yet another way to make sure that individuals and patients knew that you were going to be sharing this information, who you would share this information with, and under what circumstances you would share the information. But that's a community release form. And if you're interested in a sample of that, it is on our website as well. Then finally, we get down, I think, to what we're most comfortable with and what we most know about as it relates to confidentiality. And that is getting an individual release form between every single agency. So if you had an organized healthcare delivery system that had 12 agencies as part of it, the poor individual that you're serving would have to sign 12 individual release forms. At the moment, we're thinking that the only time that you need to use this actual individual release form is if you're a substance abuse agency and you want to share treatment information. You absolutely need to have that. And in situations where consumers have not signed the consent to treatment form, a community release form, or have not in some way agreed to allow you through these other mechanisms to share information. So you can see that what we're proposing is a pretty liberal conversation about sharing, but it's not behind the scenes. It's very open. It's discussed openly with the consumers. Just about on every form that they see from you, they know this is happening, and it becomes a core of who you are. You are an integrated healthcare delivery system. For my organization in Washtenaw County, we actually got to the point of where if individuals would not sign the release forms to allow us to talk with their primary care physicians or their other treatment providers, we actually began to not accept people into care and suggested that they would have to go somewhere else to get their care. That we were so committed to integration and we thought it was so important for healthcare professionals to share information that we didn't think in good conscience we could provide treatment to these individuals. And in several years of taking that position, I think we had 3 consumers out of thousands who said that they would like to go somewhere else, that they absolutely would not want us to share this information. We got to that point because we did start out getting an individual release for everybody every time in our integrated health services. But what we found is that everybody was signing them. So that's why we looked for the elements that I've talked about today that would allow us in a broader way to exchange information. We found only 2 categories of people who would not sign our form when we were getting individual release forms. Drug-seeking individuals did not want to sign forms and have us sharing that information. Now, that makes sense. The other group of people that wouldn't sign were people who wouldn't sign anything, and we all have some of those in the service delivery systems that we run. But with those individuals, what we said is every time we came in, we would clarify with them that they knew that we shared information with these other folks, and if they received service from us that day, we would be sharing that information and they still want to receive service. They would say yes. We would ask if they would sign the form. They would say no and say, I don't sign anything. But we would go ahead and continue to work with them and continue to help them get really solid integrated care. So that's why we moved to having the information on the consent to treatment form, to these qualified service agreements and the organized healthcare delivery system, is that 99.5% of the people that we served wanted this to happen, were supportive of it happening, and allowed us to move forward with the kinds of services that we wanted to provide. Finally, one of the things that always surprises me is that we are reluctant to share information with each other, thinking somehow that the people we're going to share it with will release it to folks who shouldn't have it. This has always been fascinating for me because all of us in the field, whether we're social workers or physicians or nurses or psychologists, we all have professional ethics statements that guard confidentiality. By the nature of our work, we are committed to only sharing information on an as-needed or as-needed-to-know basis. And so we all are, if there weren't federal or state rules, our own professional ethics would have us control this information in a way that is in the best interest of the people that we serve. We do recommend, and I'm sure most organizations have this, particularly if you're accredited, that you do create need-to-know guidelines in your organization that enhance the professional ethics statements. These would be guidelines that your staff would sign, and we did this in our organization as a new staff person would sign our organizational ethics statement. And that organizational ethics statement always had a section on HIPAA and privacy need-to-know guidelines indicating that individuals were to follow them at all times and that a failure to follow them could lead to dismissal from their position. So this is another way that in addition to getting consumers to sign on the dotted line around sharing their information, we have staff sign on the dotted line so that we can show some kinds of protections to do that. Because in the lawsuits, and there have been very few, the last I checked, I think there had been 6 lawsuits under HIPAA for information to having been released, and that's been in situations where computer systems have been compromised and folks have gone in and gotten information, so they've been big, large information breaches. I'm not aware of, and I continue to check for, a case where an individual has filed suit for an organization sharing information, and there are just very few of those. And so guarding against what often doesn't happen and not sharing the information and getting people the services that they need are critical. So let me summarize. I'm not suggesting that we share information willy-nilly with each other, but what I am suggesting is that under the federal law, under state law, under our professional guilds ethics policies, and under our organizational ethics policies, we can, within reason, share information with other individuals who are working with a patient that we're seeing to improve their health and to improve their coordination of care. In fact, I think we're getting to the place of being obligated to do that, that we have to do that and that by segregating the information and not sharing it, we may actually be creating more of a burden and more of a liability for ourselves than we need to. For documenting this, because this always comes up, it's like, okay, so we agree to share and we're going to put this all in a single record. What do you think about that? I think we have to have the mental health, substance abuse, and primary care information in one record in order to have good integrated health care. The demands on healthcare teams are such that they can't be looking through, whether it's electronic or paper, a lot of records to be finding this information. So we need to be putting it all in one record. And even better, I think we need to be doing concurrent documentation, which means that when the individual is in the room with you, the last 5 or 7 minutes, you're writing the progress note with that consumer, whether it's the physician, whether it's the social worker, or whether it's the substance abuse counselor. You're doing that documentation with the person present so that the person sees what's going into their record, and then they feel much more relieved that others are going to see it because they know what you've written. It doesn't become this secret note that we've written after they've left. So my first recommendation is that if you can, you have one record with the notes integrated into it, and that you do those notes with the consumer present so that they know what's in their record. A not so good option is to have separate records, but there are organizations where they have that. A little bit better option is in your electronic or paper record to have a section that's labeled behavioral health. Maybe it's a different color or maybe it's a different tab, but it's at least in the record so that the treating provider can get to that information if they need it. But as I've mentioned, I think the very best place to put the note is right in the physician note section, where when the physician or nurse practitioner or PA sees the individual, they'll see that the social worker has seen them, they'll see the progress that's being made, and that's when you get true integration of the body, mind, and spirit. And so that's how you can handle documentation in this process. Throughout this webinar, I've talked about a number of policies and documents related to confidentiality that might help ease your mind or provide support for the concepts that I've presented. If you go to samhsa.integration.gov, and here I do have it right as .gov, not .org. Apologize for that on the other slide. But you'll find in our website a sample integrated mental health, substance abuse, and primary care policy. It was one that was done in Michigan, but it incorporates all the things we've talked about into a single policy. You'll find a SAMHSA document that I referenced done in 2004 on HIPAA and 42 CFR. You'll find a state paper on confidentiality that allows folks to share information in Missouri. Business associates agreements, a sample privacy statement, sample consent to treatment, and then the SAMHSA frequently asked questions around confidentiality. So we've been trying to get all this information in one place, and so you can go to samhsa.integration.gov to confidentiality and find everything that I've been talking about. So that is all I have here for today's presentation, and I will now turn it back over to Jamie, and we will entertain questions, comments, feedback from those of you on the webinar. And thank you very much for your attention.